everybody. Welcome to Wound Dressing Categories with Lizzie. I am Lizzie, and I am here to talk to you about the wide variety of wound dressings and kind of give you an overarching view of what they are. If you don't know me, I'm a wound care nurse practitioner. I also am the owner of a consulting company, Lizzie Wounds. I'm the co-owner of the Frank and Lizzie Show, and I am now the president-elect of the Save a Leg, Save a Life Foundation. Our objectives, we're going to talk about the variety of wound dressing categories, their specific uses, how to select an appropriate one based upon the wound characteristics or your patient. We're going to provide some clear and detailed information around the wound dressings, what's covered by Medicare and Medicaid, eligibility criteria, documentation requirements. We're going to encourage all of our participants to adopt best practices in terms of wound management. So how do we use these tools for our patients in order to get the best outcomes and also make sure that there's coverage for it? So let's look at the types of wound dressings. In topical management of wounds, we have cleansing options. We have the basic wound dressing categories, which we're going to go through in more detail. But just to give you an overview, we have hydrogels, hydrocolloids. Those will both help contribute moisture towards the wound. Transparent films, contact layers, and gauze. Then we have foams, alginates, and hydrofibers. Those are going to handle moderate to heavy drainage. And then we have super absorbers, which is more for moderate to copious, or I'm sorry, large to copious amounts of drainage. We have advanced wound dressing products such as collagens or negative pressure wound therapy. And then we have active things that topical management like growth factors or the ever famous CAMPs, which is cellular, acellular, and matrix products, otherwise known as CTP, otherwise known as skin subs. There's a lot of buzz about them. So what is a primary dressing? A primary dressing is just the first layer of material that we're going to apply directly to the wound. So its primary function is to protect the wound from external contaminants, absorb exudate, or promote a moist wound healing environment. Primary dressings can be made up from a wide variety of materials. It can be gauze, hydrocolloids, films, foams, alginates, depending on the condition of the wound. Their purpose, they're going to facilitate healing by creating that nice, moist wound environment. Ideally, pain reduction. So particularly with wounds that are partial thickness, you're going to have some exposure of nerve endings. And so when we actually cover the wound with a moist wound dressing, it's going to help decrease the amount of pain that the patient has because we're covering those nerve endings so they're not constantly firing. Exudate absorption, and I just like to offer that it might also add moisture. Some primary dressings can add moisture, so it may not absorb a lot. So for example, a hydrogel will not absorb anything, but a hydrocolloid, because it has a little bit of absorptive category, can. But things like foams and alginates can really handle the exudate, which we often see with chronic wounds. They should be easy to remove and apply. You don't want things sticking or pulling or causing more trauma to the wound bed. They protect the wound. So keeping a wound covered doesn't necessarily mean it's shielded from the outside world, but it's certainly a nice barrier to that. It can help with temperature management as well. And then moisture management. So the whole goal really of a wound dressing is to provide that moist wound environment. And so primary dressings help fill that pretty well. So in contrast, there's secondary dressings. So when we're ordering dressings for our patients, we would often order primary dressing at least. And then if that primary dressing requires a secondary dressing, we would also order that. So a secondary dressing is simply applied over the primary dressing, which is in direct contact with the wound, to provide either added protection, support, or management of the wound environment. Secondary dressings are often if the primary dressing does not hold all of the exudate itself. So for example, like an alginate would be put directly into the wound base, and then you would need a secondary covering dressing over top of that. What can be confusing is that some dressings fall into both categories. So for example, a foam dressing could be both a primary dressing or a secondary dressing. A transparent film could be a primary dressing or a secondary dressing. A hydrocolloid could be a primary dressing or a secondary dressing. We often use them as secondary dressings when they're just securing the primary dressing in place. And you might need 2 layers of secondary dressing. So for example, if I'm wrapping an arm, I might need to put down a primary dressing and then let's say some gauze and then maybe rolled gauze over top of that. So then that would be 2 secondary dressings, but they provide protection of the wound bed. So you're covering it up. They can help with absorption. They help with stability. So basically leaving it in place. They can also be supportive, so just helping the patient feel secure about the wound. They can also help with moisture management and thermal insulation, so keeping the temperature of the wound ideal. So what does an ideal dressing do? Well, it's going to prevent and treat infection, ideally. Obliteration of dead space. So we know that wounds often have a deficit. Some can be superficial, but when they have a true ulcer where we've got like a full thickness wound, we have to fill in that dead space in order to promote wound healing. So when we fill in that dead space, we're then able to obliterate that, and that can help both move the exudate out of the wound, but also those pro-inflammatory cytokines and things that can delay wound healing. That dressing should be absorbing the exudate or at least transferring it out of the wound environment. We often want it to either debride the necrotic tissue or facilitate the debridement of the necrotic tissue. Maintenance of a moist wound environment, I can't stress this enough. Moist wound environment is the goal here. So that is the whole purpose of picking a dressing, is to create that moist wound environment. And then protection and insulation. So it is good. We do know that there's temperature loss from the wound. And so we do want to provide some insulation to promote that maintaining the same temperature, but also protecting. So sometimes I say we're protecting the wound from the patient because there's certainly home environments that maybe are less than ideal. I think of our patient population that is housing. Housing is an issue. We have to worry about where they're changing their dressings or when they're walking around. But I just think of it even with my kids, like if they get brush burn and then they're putting sweatpants on and they get all that lint in there. Or I think of my patients that just put socks over their foot wounds and there's like that bright yellow fall sock lint clustered up in there after the fact. So that's stuff we don't want in the wound bed. So what factors can affect wound healing and what are our treatment guidelines? So this is very simplistic. Obviously, it's a lot complicated than this, but we think of it as you assess the wound. So you're going to look at the things such as wound size. What tissue are you seeing? Are you seeing healthy tissue like granulation? Are you seeing non-viable tissue? Is it black non-viable tissue? Is it yellow non-viable tissue? And then what's the drainage like? And not just like quality, meaning like, is it purulent or is it thin or serous, but how much of it is there? Is there small, moderate, large? And then you want to think about all the other patient factors, which I kind of have up here in that upper right-hand corner. So let's look at things like blood flow, infection. What is the clinical status of the patient? Are they hyperperfused? Is their goal healing? Is their goal no pain? And then external factors. So who's changing the dressing is one of those big external factors that I worry about the most when I am selecting a dressing, because I certainly don't want to pick something that is twice a day if the patient can't change the dressing themselves and they don't have a caregiver that can support that either. So when we talk about the categories, I know we briefly went through them before, but we can talk about alginates and hydrofibers. I put them together because they're very similar. Collagens, composites, contact layers, foams, hydrocolloids, hydrogels, special absorptive dressings, transparent films, and wound fillers. So when we talk about a hydrogel, We're talking about a water or glycerin-based gel, and it's often in an impregnated gauze or sheets. And so what you're seeing on the right-hand side here is simply a hydrogel sheet. This can be good for more superficial wounds, but it hydrates the wound base. So it's adding moisture to the wound base. This really helps facilitate autolytic debridement. So that's using your body's own natural resources to remove non-viable tissue. It can be really soothing. So if you think of like superficial burns or superficial like road rash, hydrogel sheets, you can even throw them in the refrigerator for a little bit ahead of time and then put them on. It can be really soothing. Sometimes we see this in like a radiation dermatitis as well, that this can be like a soothing therapy for that patient. You can only use it in patients that have low exuding wounds though, because you don't want to add moisture to a wound that already has enough moisture, because then it can become macerated. The gel version, where it comes in a tube and you squeeze it out and apply it over the wound, should be changed daily because that can dry out. And so it does depend on which hydrogel you use. But there are a wide variety of options out there. So just know what your options are. I think that every institution should have at least one hydrogel on formulary as an option. In my patient population, I don't use hydrogels a whole lot, but when I need to, I love it. Hydrocolloids. So I have a 13-year-old daughter, so I included this mighty patch picture because that's the hydrocolloids we see the most. But hydrocolloids, brand names are going to include things like Duoderm, Exuderm, Comfeel, or some brand names. Again, not promotional, just offering you some of the brand names. This is occlusive dressing, so it's going to block the outside environment from the wound. And so this can be good if like your patient has incontinence and you're trying to prevent the incontinence from getting into the wound. That will create that barrier because it's occlusive. Hydrocolloids can feel a little gummy because they are. They have pectin in it. So I come from farming communities and we know what pectin is because we add it to our fruits in order to make jams and jellies. So pectin is a thickening agent. So built into those hydrocolloids is a thickening agent. And what you're going to see is that when moisture comes in contact with that pectin, it actually turns white. And so you might see the hydrocolloid itself turn from like a tan color to a white color when it's moist. And so it can actually absorb small amounts of moisture into that dressing because of that pectin, but it'll often hydrate the wound. So you can use this on drier wound types in order to help soften and facilitate some of that autolytic debridement. So it can be good for those drier wounds. It does contain an adhesive though, so you do have to be careful for the medical adhesive related skin injuries, which is otherwise known as MARSI. It's not ideal for anything that is moderate or greater, and it can be at secondary dressing. So I mentioned earlier, if we were using this on a patient with incontinence, it's a great option because it can be a barrier. I use it in my posterior trunk pressure injuries as a secondary dressing to secure it in place to help prevent incontinence from being an issue. And heat does activate it and melt it. So this is not a dressing you're going to want to leave in your car in the hot summer because it'll destroy the quality of it. But when you're applying the hydrocolloid to a patient, like some tips and tricks is I put it in my back pocket. Some people like put it underneath their armpit while they're doing the wound assessment just to kind of preheat it so that when you're putting it on the patient, it'll stick really well as soon as you put it on. The other thing is I say I kind of do Reiki over it, where I hold my hands over it for like 20 seconds and just push on the sides and make sure it's secured well, so that it's really secured on there well, so that it doesn't fall off as soon as you walk away. All right, transparent films. So these are good primary or secondary dressings. We most often see these over IV sites. We really don't think of them as wound care dressings necessarily, but they do get used. So particularly in long-term care, if they're looking at like a skin tear, sometimes they use them over those. but these are better for partial thickness wounds, sometimes stage 1 or stage 2 pressure injuries. Really should have minimal to no exudate with these wounds. Sometimes superficial burns or donor sites, but these are more used as a secondary dressing, in my opinion. And larger sheets of this are used with negative pressure wound therapy as well. But these are more of a should have in your inventory instead of your first go-to grab thing. Okay, contact layer. So contact layer is just simply a layer that you're keeping in between the wound and whatever the next dressing is. So it will always be a primary dressing. It's a single layer of low adherence that makes direct contact with that wound base for that non-traumatic removal, or if you're protecting something that you put against it. So for example, whenever I'm placing a cellular tissue product, I put a contact layer over top of that cellular tissue product and steri-strip it down so that there is another layer over top. So that's excuse me, that's one of the ways that I fixate my cellular tissue products. You also use it if you have a wound that's very friable or has a lot of pain or a lot of ingrowth, or if you're just trying to keep if the patient wants to change the secondary dressing every day, but you want the primary dressing to stay in place, you can use it. So comes in a wide variety of different types. My favorite is silicone, but you could also get like a woven net, impregnated open weave, sometimes known as a daptic. In the burn world, we use something called wound veil, which is a lot larger. But silicone's my favorite, I think, because the holes are really big and it's not oily, and so it doesn't like mess with your gloves and it doesn't slide around, and it remains tacky and you can see through it, but should really only be used for superficial wounds or again, like over top of cellular tissue products or underneath negative pressure. Gauze. So gauze are a necessary evil with wound care, primarily for cleansing, but should rarely be used as our primary dressing. And just to give you some pointers, there's really poor evidence that using gauze is beneficial in wound healing. And there is evidence that bacteria can penetrate up to 64 layers of gauze. So it's not even that you're protecting. I think one of the biggest things is that wet to dry should not be used. That is old philosophy. We have plenty of studies that show that that is not supported by evidence-based practice. And we know it's easy to order, but nurses don't often do the dressings as they should be doing it. And it can cause a lot of trauma and actually delay wound healing, and can lead to infection. So not recommended. Foam. So this is one of the most frequently used in the wound care space. And it's kind of, when I worked in our large trauma center, the one that I would recommend the most, like when in doubt, just use a foam because it can absorb moderate to heavy. So we weren't macerating wounds, and they use silicone as their primary contact layer, some of them. So they're non-traumatic, and they're kind of like set it and forget it kind of thing. But there's lots of varieties. So you can have adherent or non-adherent, meaning there's like a contact layer built into the foam that allows it to be removed easily. What you're seeing on the right-hand side is actually a bordered foam. And so that's nice because then you don't have to secure it with like a rolled gauze or tape or anything like that. Everything's built into it. Again, they allow moderate drainage. Most that I've seen lately have that silicone contact built into it, which allows it to be non-traumatic. And you can get anywhere from like a 2 to 7 day wear time out of these. And you can even peel the ones that do have the silicone back to check the wound and then kind of push it forward. And they're also used for prevention of wounds, particularly in pressure injury care. So alginate and hydrofiber. So this is just showing you when you need a wound filler that this is what it's doing. So if you're looking at that cavity, you can see that the alginate or the hydrofiber is actually filling up that cavity. And these are composed of often seaweed, calcium salt, of acid, and then calcium alginate fibers. So there's a few different things that can be used, but they exchange sodium and calcium ions, sometimes also silver, depending on the formulation. But you can also have a silver alginate gel in addition to like a fiber. The differences in manufacturing will determine like what degree of wicking and wound exudate you have. But in general, a hydrofiber, which is made by one company, is about 30% more absorptive than an alginate. So a little bit more absorptive. Don't know how to really truly measure that in your patient population. But I would say, find an alginate or a hydrofiber that you're really comfortable using and one that your staff likes. Some people like when there's ribbons run through it to make it easier for removal and cutting and things like that. Those were the ones that I really liked. But the absorption and how well it sits, I just caution you that these take on the color and appearance of the exudate that comes out of the wound. So I often warn my patients and my nurses, this is going to look like a big ball of snot when it comes out of the wound. And that's because it's taking on all the serous sanguinus or purulent drainage that the wound is putting out. And then that's going to be in this gel form that now is this mass of that. So it almost can like plop out of the wound if you're removing it. Just know like that's not the tissue, it's just the dressing. But this is one that if you put it in the wound, you have to take it out of the wound. So make sure you're not just stuffing more on top of it, because that's also important. Specialty absorptive dressings. So with these, they're often multi-layer dressings that have high absorptive layers, such as cellulose, cotton, and rayon. I compare these to like thin diapers, basically, because our diaper technology has gotten so much better, and so have our specialty absorptive dressings. So these are for really draining wounds. And it can be used as a primary dressing. It's often used as a secondary dressing with something like an alginate. Some have borders, some don't, and they're usually pretty conformable. I worry about whether or not they can be used under compression in like venous leg ulcers. But there's a lot of new super absorbers on the market, and I think it's a great need because particularly in our venous leg ulcer and our pressure injury population, we see that we have high levels of exudate often. Wound fillers. So this is kind of a random category, but it is one that gets used a lot, particularly in the post-acute space, and whether that's home health or long-term care settings. I do have an example of one over to the right here. I've personally never used that one, but just wanted to show kind of an example of it. These can be like granules, beads, powders, pastes, and basically you're just filling in a dead space with it. And so they're used as a primary dressing for deeper wounds. They're usually absorptive and they can facilitate the removal of that non-viable tissue through autolytic debridement, but they should not be used with dry wounds. You really need something that has some moisture in order to help activate these. The one that you're seeing actually has some antimicrobial through the metallic that's in it. And so they really come in a wide variety of shapes, sizes, things like that. Then you have a composite. So a composite is basically where you're combining two or more products into a single dressing to augment the purpose of it. They're usually bordered, so no cover dressing is needed. They're usually very easy to apply. They can contain adhesives that can be traumatizing to fragile skin, though a lot of them have moved to silicones. And the function really depends on what's being blended together. So there's some dressings that now have a super absorber in with a foam. So if you have a heavy hitting wound, you can kind of combine the ease of use of a foam with this super absorber that wasn't around before. But you can marry kind of two things together. Just as a large, I guess, caution, antimicrobial dressings are great. We obviously know microbes are a big issue in wound care. But there's a wide variety of claims out there. And some of our antimicrobial dressings can be doing nothing for addressing the bacteria that's actually within the wound. Some can actually be toxic to the wound. And some can really truly address the bacteria that's within the wound. So every antimicrobial product is going to have its own set of specific claims that it can make. My recommendation is that you always know what the manufacturer says about their product, what claims they can make, and use it as a tool in your toolbox. Antimicrobial dressings can be found in gauze, in foam, in hydrocolloid, in hydrofibers, in alginates, just a wide variety. And I use antimicrobials frequently when I'm trying to either prevent an issue or when I'm actually treating an issue. But I do so selectively because I don't think every patient requires an antimicrobial dressing. We talk on the Frank and Lizzie show about the wide variety out there. I would say silver is the most common antimicrobial dressing that's on the market today. But iodine has, especially Cadexmer iodine, has some really great studies out there and good claims regarding bacterial activity. Really excited to hear about how copper is both anti-inflammatory and antibacterial, and how it's going to help kind of move silver to the side a little bit. Copper is innate in our bodies, and it's something that is an essential element for us. And then honey. So I think I just have a personal love of honey. I've seen really great results with medical grade Manuka honey. And I've even seen like impregnated products, like I've been using a honey collagen that's been really successful. And I just appreciate the fact that it's not toxic to the wound bed. It can help with like autolytic debridement and helping that osmotic shift in order to help get some of the bacteria out of the wound bed. And it just smells good. Some forms of honey are a little bit harder to deal with because they're gel, but there's great options across the board. So topical solutions. I took this picture at a CVS a while ago, but they have one of the most robust wound care selections out there. So, there's some over-the-counter and prescription topical solutions as well. So we think of things as like wound cleansers, antibacterials, steroids, debridement agents that your patients may be putting on before they come to you, or sometimes they use it in conjunction. So like my stepdad had pressure injuries at his end of life, and lidocaine gel, when prescribed, was $300. But when we went to the grocery store, went to CVS, we found this lidocaine 4% topical anesthetic, and that's what we used with him at his dressing changes in order to help control his pain a little bit better, and it was like $13. So you may have to have this happy medium of helping your patients at the home setting. You just want to make sure that whatever you're putting onto the wound is not going to be detrimental for the wound healing. But we also live in an area where there's a high Mennonite and Amish population. And so they have this drawing salve that is in the stores, and it's like this black tar looking stuff. And that's like a debridement agent. And it helps almost like the honey does with that osmotic shift of drawing out whatever is nasty in the wound bed. And so just be aware of what either your patient's using from a cultural standpoint, or is like local legends, or that they're getting over the counter, because oftentimes they've treated it for a while before they've come to you. Then you've got wound cleansers. So wound cleansers, they use fluids to remove like loose articles or non-adherent like contaminants. All wounds should be cleansed at every dressing change. And that was like eye-opening when I realized that not everybody does that, but that's my big push, is that you really need to cleanse the wound at every dressing change. What I find is when I'm talking to nursing students is they often are hesitant because they're afraid it's going to hurt the patient. And so having discussions around pain management is going to be very important during this whole process. And it's also why I like to take the approach of soaking a wound with a wound cleanser and then gently wiping it away versus like aggressively scrubbing a wound. But certainly different wounds will need different things. So you just want to make sure that you're not overly traumatizing a wound from cleansing it. You want to avoid cleansers that are toxic to healthy tissues though. So, and that's well studied, well documented. So things like hydrogen peroxide, hypochlorite in higher concentrations, particularly chlorhexidine is not good for open skin. And betadine can be toxic to fibroblasts and keratinocytes. So you just want to be cautious in using it within the wound bed. Over like a stable eschar might be good, but betadine can be toxic. So it's an iodine solution that's used to help keep things dry. And it's ideal for things like gangrene or arterial ulcers where the goal is not healing, but to keep it dry and antibacterial. It stains the skin and it stains you. So make sure you keep your white lab coat out of the way and your shoes, and really try to control when you're putting this down. And then you should just watch if they do have an iodine allergy. I would caution you to try to pick a different selection for topical management just to avoid any potential allergy. Collagenase, so you can see the brand name over to the right. There's only one enzymatic agent on the market right now. This is in a petrolatum base, and it allows for selective debridement of necrotic tissue from the wound edge. So basically, this enzyme that is in the petrolatum base cleaves collagen from the edges of the wound in. It does need exudate or liquid to activate the enzyme. So if your wound is not draining much, you have to put like a moistened gauze over top of it. And it's a daily dressing change, and it does require a cover dressing. 30-gram tube, which is what you see over to the right, is about $300. So we typically reserve it for smaller wounds. It's also used a ton in the burn space. It also can help with maintenance, debridement of the wound. And it's just, there's a learning curve with it. One of the things that I like is that the manufacturer actually has a list of dressings that will inactivate the enzyme on their website. So make sure you're picking a secondary dressing that does not inactivate the enzyme that you're hoping to use. Collagen dressings. So collagen is an abundant protein in the body, and it's an essential part of wound healing. There's a wide variety of different collagen types and dressing types. That could be its own lecture in and of itself, whether it's like a type 1 or native or what animal source it comes from. But they are known to help stimulate new tissue growth, and they can mitigate inflammatory processes from using it like a sacrificial substrate. So if you put collagen into a wound, you're essentially telling your wound, look, here's all the things that you need. I'm putting it on your mantle. Please eat this up. And then while your wound is kind of eating up all the things that you're putting in that wound with the collagen, your body is starting to remodel that wound from the base and kind of get in there and be like, okay, now we can do some healing. You can see what it looks like when you put it on dry, which is that lower picture. And then once it's moistened, how it looks up top. It can be used in superficial or full thickness wounds, typically not for necrotic wounds, but a little bit of slough is okay. And it can be more expensive than other dressings, but I would say collagens are one of my favorite dressings to use. What's also really nice is that a lot of them are resorbable, meaning that your body uses them up, and then it's not like you're stuffing it in the wound and taking it back out. Your body uses it and then it kind of disappears. So if there's collagen in the wound base when you go to change the dressing the next time, then your body may not, like your patient's wound may not need a collagen if it's still hanging out there because it didn't use it. Negative pressure wound therapy, by far one of my favorite things to use in wound care. It's been around for 30 years now, first introduced in 1995 for the treatment of acute wounds. Traditional therapy, it ranges from -75 to -150 milligrams of mercury pressure. That's to remove cellular debris and exudate, to proliferate granulation tissue formation, to promote angiogenesis, microstrain and macrostrain. So macrostrain is pulling the edges together. Microstrain is encouraging the granulation tissue to kind of fill in the dead space. And there's more advanced options. So there's things like for open abdomen, there's incisional negative pressure wound therapy, there's installation therapy, there's single-use therapy, there's home therapy, there's hospital therapy, there's a wide variety, and I think we're going to be seeing more. There's a lot of growth in this space, so more to come, but definitely should get training if you're using negative pressure wound therapy. There's this new dressing which is featured, which is an all-in-one known as a peel in place that allows you to simply take the one dressing off, put it over the entire wound, no more cutting foam and things like that. So I think there will be a lot of advances in the next few years, and hopefully we can update this. Just if you are doing a negative pressure dressing change, the steps are going to be to prepare your supplies, assess the wound. If you're using traditional negative pressure, you would cut the foam to the size of the wound, not over the wound, because you don't want fragments to go into the wound. And then secure it with drape and attach that negative pressure suction disc, otherwise known as a track pad, over top of it and turn on the machine. And then that stays in place for 48 to 72 hours before you have to change it again. So it's a nice option, one, because it's occlusive. So like in this patient, she has an ostomy directly next to the wound. And so we're able to protect the wound if that ostomy were to leak, that it's now covered with an occlusive dressing. So the ostomy output will not get into the wound. All right, so when should you reevaluate a wound? So if the removal is causing pain or bleeding or trauma to the surrounding skin or to the wound itself, if you have to soak it to remove it, good idea to change your dressing. If you see a lot of maceration, you either need to change your dressing or change the frequency of your dressing changes. And if the dressing needs to be changed more frequently than you've prescribed it. So this is a busy slide, I'm aware, but I'm going to guide you to go to whatever your insurers or your patient's insurers surgical dressing policy. So wound dressings fall under surgical dressing category. And if you can see this on the upper right-hand side is a surgical dressing reference chart data. And it takes you through what is the dressing type, what kind of exudate you need, what thickness the wound has to be, and how frequently you can change it. And so, for example, if I'm prescribing a foam, I know that in my documentation, I have to have one, the size of the wound, two, the amount of drainage, three, that it's a full thickness wound, and then four, that I'm changing it 3 times a week. So if I'm ordering a month's supply, I'll be able to get 12 for the month, and that's what I'd order. The chart on the left is just showing you the drainage level and how frequently you change it. These are just 2 different ways of looking at similar data. All right, so conclusions. Drivers to dressing selection should be wound exudate is like one of the biggest things. So the type of exudate, whether it's low, moderate, or heavy, really determines the type of dressing you need. You would never want to put a hydrating dressing on a very draining wound. Coverage. Of course, it's great to get coverage. You can order whatever you want, but if it's not covered, your patient probably won't use it. So make sure you're aware of your Medicare policies. Most insurers follow that, but there can be some hiccups. So make sure you check with each one individually or partner with a DME that will do that for you. Wound properties. So you want to consider things like wound depth. You know, do you need to fill in the wound? What's the peri-wound look like? How fragile is their skin? What's the tissue base? Is it infected or necrotic? To really guide your choices in selecting that dressing. And really effective dressing selection is essential for promoting that wound healing and preventing complications, tailored to unique characteristics of the wound. So you are just the matchmaker here. You are thinking of that wound assessment and the patient factors the entire time you're looking at the wound and thinking, what am I going to use to match? I would say I try not to change the dressing category for at least 2 weeks if it's chronic wound, just to see how it does with the new one, unless there's issues such as maceration, trauma, infection, things like that. All right. We'd love to hear questions from you or comments below. Please be sure to subscribe to the Frank and Lizzie show for all of your wound dressing categories and wound ostomy and lymphedema education. Thanks. Hi everybody, thanks for watching our wound dressing categories with Lizzie series. Today, I just want to guide you through the systematic approach of evaluating different brands of wound dressings. With so many options on the market, it's really essential to choose the right product for your patient's needs, using a key few steps to make an informed decision. So step 1 is identifying your clinical needs. Understand the specific clinical needs of your patients, including types of wounds you frequently encounter, what size they are, and what healing challenges you face, including moisture or infection. Step 2, review the product specs. So you want to look at the specs of each dressing brand, paying attention to things like materials, absorbency, and any unique features that may benefit your patients. Ensure the product aligns with the clinical needs you've identified. Step 3, consider cost effectiveness. You want to evaluate the cost of each brand in relation to its benefits. While some dressings may be more expensive, they may have longer wear time. Step 4, you want to examine the clinical evidence. So this is really important. Every rep's going to have a claim. You have to back it up. So look at the things that support efficiency. Make sure that there's some literature to support what they're stating, and at least the IFU. How it's going to promote healing is important. Step 5, gather patient and clinician feedback. So consider feedback from both patients and clinicians who have used the product. Real-world experiences can provide invaluable insights into the dressing's performance, comfort, ease of use. I like to use the fist of 5 technique, where the fist means you would actively fight against bringing the product in, and 5 is that you would become the product champion. You love it so much. This offers objective metrics to compare between dressings. Step 6, evaluate your supplier support and availability. So in acute care, it may be what contracting you have. If you're outpatient, it's what DME. And also the company. What support does the company? Do they provide education? Do they have educational sheets? Things like that. So by following these steps, you can make a well-informed decision when evaluating a wound dressing brand that ultimately enhances your patient care and your outcomes. Hi everybody, welcome back to Wound Dressing Categories with Lizzie. Today we're going to talk about open to air. When it comes to wound management, the approach of leaving a wound open to air has been a topic of discussion among healthcare professionals for years. The evidence says moist wound healing is preferred. Research shows that moist wound healing is more effective than leaving it open to air. Broke that old wives' tale. Keeping a wound moist can promote faster healing, reduce pain, and minimize scarring. Exposing the wound to air can lead to desiccation, which slows the healing process. Open wounds are more susceptible to contamination and infection. Studies indicate that covering wounds with appropriate dressings, as we've discussed, can provide a barrier against bacteria and other pathogens, reducing the risk of infection and promoting a healthier environment. Additionally, exposed wounds are more painful due to increased sensitivity to air and environmental factors. Evidence suggests that covered wounds often experience less pain, as dressings can provide a protective layer that minimizes exposure to irritants. Clinical studies have demonstrated that wounds managed with occlusive or semi-occlusive dressings heal faster than those left open with air. The moist wound environment created by these dressings supports the cellular migration, leading to quicker recovery times. While there may be some specific cases where leaving a wound open is appropriate, such as more superficial abrasions, the general consensus is that moist wound healing is the gold standard.
Make sure you pick an appropriate dressing for that moisture balance and always consult with a healthcare professional if it's a personalized wound care advice. Be sure to subscribe to the Frank and Lizzie show for more wound dressing categories with Lizzie.
Hi everyone, welcome back to Wound Dressing Categories with Lizzie. I'm excited to dive into the world of Solventum vac therapy and its transformative impact on wound care in the hospital setting. So we're going to be talking about the Vac Ulta machine. I've used vac therapy firsthand and I can tell you it is a total game changer. This Ulta unit offers 4 innovative therapies that are essential for managing a wide variety of wounds in acute care. First, we have the Apthera. So this is the Apthera dressing. It's great for temporary abdominal closure. Next, if you have a surgical wound, is Prevena therapy, perfect for managing surgical incisions and helping protect them post-operatively. Of course, we cannot forget about vac therapy. It is the OG negative pressure wound therapy, and its trusted effectiveness and versatility has been around for over 30 years. And last but definitely not least is Vac Veriflow. It takes it one step further by combining negative pressure wound therapy with installation, can help enhance a wound bed, facilitate the removal of cellular debris from the wound base, and some dressings can even provide a hydromechanical removal of non-viable tissue in a closed automated system. Using Veriflow completely changed my practice. I started using it with dirty wounds and then used it for post-surgical wounds that were stalled, and really just any wound in the acute care setting due to the great outcomes I was seeing. These therapies are not just for complex wounds, but they're suitable for a wide range of wound types, big or small, making them totally invaluable for acute care settings. Hey everybody, welcome back to Wound Dressing Categories with Lizzie. Today we're going to be diving into the world of antimicrobial dressings that aren't silver. Because let's face it, silver gets all the spotlight, but there's some heavy hitters of antimicrobial lineup that deserve your attention. Silver isn't always the right choice, and sometimes we need alternatives due to sensitivities, costs, biofilm, complexity, local formularies, a wide variety of things, but there's some solid scientific backing. So let's go through the most common non-silver antimicrobial dressings, which a lot we've previously discussed in these episodes. Iodine-based dressings, so these are like povidone iodine or cadexamer iodine. They're great for moderate to high bioburden, and they release iodine slowly, keeping the bacterial load in check without harming healing tissue. PHMB, which is found in gauze, foam, hydrofiber styles, is broad spectrum activity, includes biofilm disruption, less cytotoxic than some other alternatives. It makes it good for maintenance phase. Honey-based dressing like Manuka honey, naturally antimicrobial, also promotes autolytic debridement, ideal for wounds with odor, slough, or mild to moderate exudate. Methylene blue and gentian violet dressings, they're dual action antimicrobial dyes that are broad spectrum and they can bind to endotoxins, excellent for stalled wounds or wounds with bioburden. Last but not least, copper-based dressing. So copper is also a broad spectrum, and it helps with tissue regeneration. They can help modulate inflammation and promote angiogenesis. And just remember that choosing your antimicrobial dressing isn't about what's trending. It's about matching the product to your patient's wound characteristics, comorbidities, and healing phase. If silver isn't an option, there's plenty of other evidence-based antimicrobials out there. Hey, it's Lizzie. Welcome back to Wound Dressing Categories with Lizzie. Today we're going to talk about silver-based wound dressings and how they work as antimicrobial agents. Silver's been used in medicine for centuries, but in wound care, it's valued for its broad spectrum antimicrobial properties. And so when silver dressings come into contact with wound exudate, the silver ions are released. These ions are an active component, meaning they attack microbial cells in multiple ways. They can disrupt the bacterial cell wall and membrane, which leads to cell death. They can bind to proteins and DNA inside the microbe, interfering with replication and essential functions of the bacteria. And they can inactivate enzymes that bacteria need to survive. Because it's multi-targeted, silver dressings are effective against a wide range of pathogens, including some of our resistant organisms.
There's also many types of silver dressings, including foams, hydrofibers, alginates, mesh, and some release silver continuously or sustained. Some are activated when moisture is present, and concentration of the silver also matters. Too much silver can be toxic for a wound. So there's lots of different silver dressings on the market. It's important to understand the mechanism of action for each one that you select. So match the level of exudate with the type of dressing. And if you want silver to be impregnated in it in order to help offer some antimicrobial, that is the best way to do it. Use it short term only when there's suspected colonization or localized infection, and reassess as needed every 2 weeks. Thanks for tuning in. Be sure to subscribe to the Frank and Lizzie show for more wound dressing categories. Next week, we're going to conquer some other antimicrobial categories. Hi, everybody. Welcome back to Wound Dressing Categories with Lizzie. Today, we're going to talk about open to air. When it comes to wound management, the approach of leaving a wound open to air has been a topic of discussion among healthcare professionals for years. The evidence says moist wound healing is preferred. Research shows that moist wound healing is more effective than leaving it open to air. Broke that old wives' tale. Keeping a wound moist can promote faster healing, reduce pain, and minimize scarring. Exposing the wound to air can lead to desiccation, which slows the healing process. Open wounds are more susceptible to contamination and infection. Studies indicate that covering wounds with appropriate dressings, as we've discussed, can provide a barrier against bacteria and other pathogens, reducing the risk of infection and promoting a healthier environment. Additionally, exposed wounds are more painful due to increased sensitivity to air and environmental factors. Evidence suggests that covered wounds often experience less pain, as dressings can provide a protective layer that minimizes exposure to irritants. Clinical studies have demonstrated that wounds managed with occlusive or semi-occlusive dressings heal faster than those left open with air. The moist wound environment created by these dressings supports the cellular migration, leading to quicker recovery times. While there may be some specific cases where leaving a wound open is appropriate, such as more superficial abrasions, the general consensus is that moist wound healing is the gold standard. Make sure you pick an appropriate dressing for that moisture balance, and always consult with a healthcare professional if it's a personalized wound care advice. Be sure to subscribe to the Frank and Lizzie show for more wound dressing categories with Lizzie.
Hey everybody, and welcome back to Wound Dressing Categories with Lizzie. Today we're going to be diving into the world of antimicrobial dressings that aren't silver. Because let's face it, silver gets all the spotlight, but there's some heavy hitters of antimicrobial lineup that deserve your attention. Silver isn't always the right choice, and sometimes we need alternatives due to sensitivities, costs, biofilm, complexity, local formularies, a wide variety of things. But there's some solid scientific backing. So let's go through the most common non-silver antimicrobial dressings, which a lot we've previously discussed in these episodes. Iodine-based dressings, so these are like povidone iodine or cadexamer iodine. They're great for moderate to high bioburden, and they release iodine slowly, keeping the bacterial load in check without harming healing tissue. PHMB, which is found in gauze, foam, hydrofiber styles, is broad spectrum activity, includes biofilm disruption, less cytotoxic than some other alternatives. It makes it good for maintenance phase. Honey-based dressing, like Manuka honey, naturally antimicrobial, also promotes autolytic debridement, ideal for wounds with odor, slough, or mild to moderate exudate. Methylene blue and gentian violet dressings, they're dual action antimicrobial dyes that are broad spectrum, and they can bind to endotoxins, excellent for stalled wounds or wounds with bioburden. Last but not least, copper-based dressing. So copper is also a broad spectrum, and it helps with tissue regeneration. They can help modulate inflammation and promote angiogenesis.
And just remember that choosing your antimicrobial dressing isn't about what's trending. It's about matching the product to your patient's wound characteristics, comorbidities, and healing phase. If silver isn't an option, there's plenty of other evidence-based antimicrobials out there. Be sure to subscribe to the Frank and Lizzie show for more wound dressing categories with Lizzie. Hey, it's Lizzie. Welcome back to Wound Dressing Categories with Lizzie. Today we're going to talk about silver-based wound dressings and how they work as antimicrobial agents. Silver's been used in medicine for centuries, but in wound care, it's valued for its broad spectrum antimicrobial properties. And so when silver dressings come into contact with wound exudate, the silver ions are released. These ions are an active component, meaning they attack microbial cells in multiple ways. They can disrupt the bacterial cell wall and membrane, which leads to cell death. They can bind to proteins and DNA inside the microbe, interfering with replication and essential functions of the bacteria. And they can inactivate enzymes that bacteria need to survive. Because it's multi-targeted, silver dressings are effective against a wide range of pathogens, including some of our resistant organisms. There's also many types of silver dressings, including foams, hydrofibers, alginates, mesh, and some release silver continuously or sustained. Some are activated when moisture is present, and concentration of the silver also matters. Too much silver can be toxic for a wound. So there's lots of different silver dressings on the market. It's important to understand the mechanism of action for each one that you select. So match the level of exudate with the type of dressing. And if you want silver to be impregnated in it in order to help offer some antimicrobial, that is the best way to do it. Use it short term only when there's suspected colonization or localized infection, and reassess as needed every 2 weeks. Thanks for tuning in. Hey everyone, welcome back to another episode of Wound Dressing Categories with Lizzie. I'm Lizzie, and I'm going to dive into iodine-based dressings today. So we're going to start with the basics. Iodine-based dressings are antimicrobial. They're wound dressings that help reduce bioburden. They come in different forms like gels, foams, pads, and they slowly release iodine to fight bacteria, fungi, and even viruses. I've worked with a few different ones over the years. So IotaFlex, that's Cadexmer iodine pad. The Cadexmer iodine combines iodine at 0.9% with Cadexmer beads, which are starch-based, so they're hydrophilic, and they're little microspheres. They absorb a ton of exudate and they handle odor very well. Super helpful for sloughy wounds and anything that needs both exudate management and antimicrobial. Iodosorb is the same technology, but a gel form, great for packing or deeper wounds, though you do have to irrigate it out. Ioplex by Medline is a new favorite. It's a foam dressing with controlled iodine release. Found it particularly helpful when you just want an all-in-one for exudate and antimicrobial. When using iodine dressings, make sure you don't use them on dry wounds. Apply to a wound with some exudate to activate the release of the iodine. It can be great for heavily draining wounds. Watch the wear time. So IotaFlex and Iodosorb both change colors when you've used up all the iodine, but they have a wear time of up to 72 hours. Layer smart. With some things like Ioplex, you often don't need additional foam covering, but you can stack it. But with IotaFlex and Iodosorb, you have a secondary dressing that's needed. Just use cautiously in patients with iodine sensitivities, if they're pregnant, pediatrics, large burns. Expect some staining with these because the iodine can stain the wound bed and surrounding skin. Not a sign of harm though. And there's other brands out there. I just don't have experience with them. So be sure to comment below what your favorite brand is. But iodine dressings are a very powerful tool in an antimicrobial toolkit. Be sure to pick the right one for your patient's needs. Welcome back to Wound Dressing Categories with Lizzie. This week we have a very unique category of odor eliminating dressings. This category is not really thought of that much because it's a secondary dressing and it's only addressing wound odor. I often wonder how many clinicians lost their sense of smell during the COVID-19 pandemic and no longer have the capacity to even assess wound odor. However, These dressings are always used as a secondary dressing. They're not going to be a primary dressing, and they're used to mitigate the smells that wounds can have. This is particularly important in patients with oncological wounds, such as fungating tumors, where odor can be significantly impacting the patient's quality of life or their care team and causing some distress. Odor could be from anaerobic or aerobic bacteria as well as necrotic tissue. There's two main players on the market today, with one of them being kind of new. So the first is activated charcoal. That's been around for a while. It absorbs the odor molecules to mitigate the smell. An example of this dressing is like Carboflex. The newer dressing to the market is Cinesteam, and this is a secondary dressing made out of cinnamon. And it not only absorbs the odor, but it also releases a more pleasant odor then of the cinnamon. I think it's important to know that if your wound has an odor, that you need to address the source of the odor as well. If it's bacteria, please use an antimicrobial cleanser and or dressing as your primary dressing. And if the wound has a lot of necrotic tissue, of course, you still have to debride the wound in order to address it. So if odor persists beyond that, you can use an odor eliminating secondary dressing as mentioned.
Hi, everybody, and welcome back to Wound Dressing Categories with Lizzie. Today, we're going to talk about an enzymatic debridement agent, Santal, also known as collagenase, currently the only enzymatic debridement agent in the U.S. market for chronic wounds. So Santal contains collagenase, which is an enzyme that selectively breaks down denatured collagen, often in necrotic tissue, and that doesn't harm healthy tissue. That makes it especially helpful for wounds where mechanical or especially sharp debridement aren't appropriate or not possible, maybe because of your skill set. By removing that devitalized collagen, Santal helps reduce the bioburden and inflammatory barriers, creating an optimal environment for wound healing. It's often used in combination with moist wound dressings to maintain the enzymatic activity. It can also be safely used alongside topical antimicrobials, so think like hypochlorous acid, making it a flexible option in complex wounds. It is a daily application, however, so remember that. Santal in a moist environment becomes active. If it dries out, it's inactive. So pair it with an appropriate secondary dressing. You do want to use caution with some antimicrobials such as silver and iodine dressings. Some of them can deactivate the enzyme, so just check the list. It's on the website. And a little goes a long way. Apply at least 2 millimeters thickness. That's about the thickness of a nickel to remove that necrotic tissue. So if you're managing a wound with devitalized tissue but can't perform a sharp debridement, or you're just trying to promote continued debridement in a slow healing wound, Santal might be your go-to. Don't forget to like, subscribe, and share the Frank and Lizzie Show for more episodes. Welcome to Wound Dressing Categories with Lizzie. We're going to talk about Veris today, which is a combination honey and collagen dressing. It's an advanced biological dressing that's really made some waves here at WOCN Next. It's made by a company, Sweet Bio. It's a smart blend of Manuka honey and porcine collagen, and it's packed into a resorbable sheet that's designed to promote healing from the inside out. The honey brings the natural antimicrobial and the anti-inflammatory properties that we talked about already. The collagen helps jumpstart that stalled wound and supports the healing cascade. Again, we already talked about this in the collagen, but this innovative product is really mess-free, meaning it's non-sticky, dissolves into the wound bed, and because of this, it can seem a bit brittle. So when you're opening the package, it can also have a scent of honey. You can hydrate it before applying it, and it does not require placing down one side or the other. It's indicated for partial or full thickness wounds, including diabetic foot ulcers, pressure injuries, surgical wounds. And it really stands out because it's a stay in place, it dissolves over time, there's less disruption to the wound, less pain for the patient during dressing changes. And if you're managing a stalled wound or one with a heavy bioburden, it's probably a great innovative option. If you've tried this, let me hear about it. I know it's new to market, but it seems like a great new option. Market disruptor. Welcome back to Wound Dressing Categories with Lizzie. Today we're diving into the world of super absorbers, which is a critical category for managing high exudative wounds. Super absorbers are designed to handle large volumes of exudate, making them ideal for wounds with heavy drainage. They contain polymers, cellulose, cotton, or rayon that can absorb and retain fluid, which helps keep the wound environment moist while protecting the surrounding skin from maceration. The dressings are used as secondary dressings, usually in wounds that are full depth, and they're not indicated for wounds that have a large burden of necrotic tissue. There's some clinical tips for super absorbers, such as assessing the wound. So making sure you're selecting a super absorber for a high level of exudate. These are really the only indications for those wounds. Wound types are going to be venous leg ulcers, pressure injuries, and atypicals. Choose the right size. So ensure the dressing covers the entire wound bed and a little bit of the peri-wound. That's going to help prevent leakage as well as maceration. And don't make the mistake of ordering a larger size because of the level of exudate. Make sure you change it regularly. 3, consider the patient comfort. In addition to making sure you're changing it regularly, make sure that it's evenly placed over the wound bed so that it makes intimate contact and does not bunch up or cause discomfort for the patient. This can happen particularly under compression therapy. Super absorbers are a fantastic option for managing heavy exudating wounds, and they promote healing while protecting the peri-wound skin. Remember, the right dressing can make all the difference in wound care. Welcome back to Wound Dressing Categories with Lizzie. Today we're going to talk about a method I'm sure you've probably heard of, but hopefully you're not using it anymore, and that is wet to dry dressing. So this dressing was once used for mechanical debridement. Why? Because you could pack a moist gauze into the wound, let it dry, and then pull it off, removing the dead tissue in the process. But here's the problem. It's non-selective. That means pulling off healthy tissue too, which is super painful for the patient, labor intensive for the staff, and it doesn't support a moist wound environment, which we know is essential for wound healing. Additionally, there's an increased risk of infection and delays in wound healing with wet to dry dressings. So why is it still around? If I could answer that. Well, often it's habit, it's outdated protocols, or just limited resources, or even knowledge deficits. By following evidence-based practice, we have better options like moisture retentive dressings, enzymatic agents, autolytic debridement that are much gentler and more targeted. So what's the bottom line? Wet to dry dressings are considered substandard standard of care in most modern wound protocols. If you see them, you should say something. Move your practice forward. Don't keep it in the past. This week on Wound Dressing Categories with Lizzie, we're going to talk about a special foam dressing called Hydrofibers. Comes in 2 main forms, the Hydrofibers Classic or Ready. Classic is made from a polyvinyl alcohol sponge and it has to be moistened before you can use it. Whereas the Ready version is made of a polyurethane foam and does not require pre-moistening. There's lots of different varieties of each of them. There's a newer one that's called Hydrofibers Comfort Cell, which can be used under negative pressure wound therapy, so that's pretty unique. It's an antibacterial absorptive foam. It has methylene blue and gentian violet, which are antimicrobial dyes. The cells disrupt the membranes and inhibit growth, which is a broad spectrum activity. Some of the features and benefits is that it's absorptive, but it also absorptive, I should say, for moderate to heavy is the requirement, but it can support autolytic debridement. And there's this color change indicator where the dressing turns from blue to light blue to gray to whitish, and that cues that it's time to do a dressing change. Often used under compression and us WOCNs, happy WOCN week. Know that it can also be used in pro-inflammatory wounds or in autoimmune wounds such as pyodermic gangrenosum, even under ostomies. Change it every 1 to 3 days, and it is a great dressing for a wide variety of wound types. Welcome to Wound Dressing Categories with Lizzie. I'm here to talk to you today about Polymem, which is a polymeric dressing that has a polyurethane dressing that has both a wound cleanser as well as a glycerin as well as a super absorber. And while it's technically a foam and requires moderate drainage and gets changed 3 times a week, it's its own unique category in my professional opinion. I love it and I use it on a wide variety of wounds. So what's interesting about it is that it actually can help promote moisture, but is also absorbent. It helps clean the wound and facilitate the removal of necrotic tissue through autolytic debridement. It helps protect the peri-wound because it actually does not horizontally wick, it just vertically wicks, so you can see the imprint of the wound when you remove the dressing. Dressing removal is atraumatic, and so it also helps with pain. You don't have to change the dressing every day. Actually, it helps if you leave it in place for several days, so it's a nice cost-effective dressing as well. And I just think it's a really excellent dressing for a wide variety of wound types. I know burns have a lot of use in them. We've used them in IV drug use wounds that have necrotic tissue because those patients are very pain sensitive. It also comes in an antimicrobial version, which is silver infused, as well as a bordered version, which I haven't gotten to use yet, but if you've used it, I'd love to hear about your experience. Welcome to Wound Dressing Categories with Lizzie. This week we're going to be talking about absorptive dressings. You might think that a lot of dressings are absorptive, but this is actually a special category that includes dressings that are specially designed for moderate to heavy exudate. They're multi-layer often, and they include a variety of different highly absorptive layers. The fibers that are used are typically cellulose, cotton, rayon, and they are highly effective not only in managing the exudate, but also locking it away. Some of the absorptive layers can gel when they come in contact with the exudate. They can be used as either a primary or a secondary dressing, and they can be super beneficial for venous leg ulcers or other highly exudating wounds. We use them a lot in our total contact cast to help prevent some of that maceration. Today we're going to talk about Hydrofibers. Last week we talked about Alginates, and these two dressings are very similar, but there's just a few things you should know about Hydrofibers that are unique. Both Alginates and Hydrofibers are highly absorptive, and when they make contact with the exudate, they gel. That should be easy, non-traumatic removal. Alginates are made from seaweed, whereas Hydrofibers are made from a synthetic material called carboxyl methyl cellulose, otherwise known as CMC. Alginates are biodegradable, but Hydrofibers are not. And Alginates offer more hemostatic properties, whereas Hydrofibers are primarily focused on exudate management. Alginates absorb 20 times their weight in fluid, while as Hydrofibers hold 30 times their weight in fluid. One of the main differences I saw in clinical practice was Hydrofibers were offered in a woven form, which made placing and removing them much easier. Hydrofibers are also changed every 1 to 7 days, depending on the exudate level, and are contraindicated in low exudating wounds. I used Aquacel AG a lot in my practice, so I also know there's silver impregnated options. Welcome back to Wound Dressing Categories with Lizzie. Today we're going to talk about calcium alginate wound dressings. They've been around for a while, and they're made from a natural fiber called alginate, which actually is found in seaweed. They are known to absorb excessive fluid while maintaining a moist wound environment, so much like seaweed. But it's noted that they can absorb up to 20 times their weight. They also have an ability to create this gel-like consistency when they come in contact with wound exudate. And that's so important to tell not only your patient, but their caregivers who might be changing the dressings, because essentially when you remove the dressing, it can look like a big ball of snot, and it's going to take on the color of whatever wound exudate there is. Because they're primary dressings, they will also require that secondary dressing. Because of that gelling nature, they also help promote that autolytic debridement. They're great for moderate to heavily draining wounds, such as pressure injuries, venous leg ulcers, surgical wounds, and you can use them in areas of tunneling and undermining as well. And while the gelling nature makes it kind of trauma-free with the removal, it should be noted that some of the fibers can get left behind, so making sure you're properly cleansing to ensure there's appropriate removal of everything before putting on a new dressing. Lastly, they can also be impregnated with antimicrobial agents such as ionic silver.
Okay, this week we're going to talk about contact layers. So contact layers are a little strange because you may not think of them as like a true wound dressing, but maybe like an accessory, but they can be a primary dressing. So contact layers are put directly against the wound base, and they're typically a non-adherent so that you're protecting the wound from whatever else you're putting on it, or you're just trying to decrease the patient's pain. So I use like an oil emulsion contact layer on wounds when there's a lot of friable tissue and I don't want any of this secondary wound dressing to adhere. I love silicone contact layers because the silicone will help stick to dry, intact skin. And then you can see the wound if it's small and partial thickness. And any exudate can move through it. And it's very skin friendly. And then there's some contact layers that have no moisture to them as well. So we used one in the burn community called Wound Veil, and we use that over grafts and things like that. So wound contact layers can be changed every day for some of them, depends. But sometimes you can get away with them being changed just once a week. So tell me, what's your favorite contact layer and why? Today we're going to talk about collagen dressings. And so what I was taught about collagen dressings was that they're really great for inflammatory wounds. And that's true because they can help with delayed wound healing in terms of decreasing the MMPs that are in the wound base, and in order to project the wound onto a proliferative phase rather than an inflammatory phase. So it's used a lot in tunneling areas. And one of the nice things about a lot of collagen dressings is that you don't have to remove them from the wound base unless they're in a composite dressing like an alginate. They also create like a gel against the wound base that is like non-adherent, but it cannot be a dry wound. Collagens have to be changed usually every 1 to 3 days. It really depends on how much exudate you have, how large the wound is. There's certain collagens that are combined with other things. So like one that I love to use was combined with a little bit of ORC, and that helped decrease the bleeding in the wound as well if it was like a friable wound. But I've also used it a ton in tunneling areas or undermining, which is great because you don't have to pull it out. So you use it if you need to, and it helps kickstart the wound, for lack of a better word. Will require secondary dressing. So tell me, what are your favorite collagens? Do you use powders? Do you use a composite? Do you use the one with ORC? Love to hear from you guys.
Last week we discussed foam dressings for prevention. This week we're going to talk about it for treatment. Foam dressings are typically made of hydrophilic polyurethane. So hydrophilic meaning that they absorb, they like water. They are great at absorbing exudate. Most foams have silicone contact layers, but not all of them do. We also have bordered versus non-bordered foams. Make sure you're selecting the correct size for the wound itself. Another thing, they get changed every 3 to 5 days, but really depends on the level of exudate. And we're also not talking about impregnated foams. So there's a wide variety of foams that are impregnated with different materials. This is just talking about your kind of run-of-the-mill generic foam dressing. We typically change our foam dressings when the exudate has reached 3 borders, but you just want to make sure that you're not having peri-wound maceration because you don't want the exudate to sit on the healthy skin. And then in terms of depth, you can use it on full thickness wounds. You can use foams as a primary dressing or as a secondary dressing. And there are some foam dressings that now can actually like expand into the wound a little bit and conform into the shape of the wound to help prevent from pooling of exudate. So that's a great option to check out as well. All right, be sure to stay tuned.
This week on Wound Dressing Categories with Lizzie, we're going to discuss honey dressings. So medical grade Manuka honey is what is used in honey dressings that are on the market. Just note, you can't use any honey. It's the medical grade Manuka that you should be using. These dressings can actually come in a variety of forms. So it can be a gel, it could be a sheet, it could be a composite dressing, meaning like it's impregnated into, let's say, an alginate or something like that. So Drainage is going to depend on what you have it in, and also frequency of dressing change depends on which form you get it in. Why would you use a honey? Well, it lowers the pH and can help decrease bacterial growth in the wound bed. It also helps promote autolytic debridement of the wound, so it can be good in wounds that have some necrotic tissue like slough. Not great over eschar, and they may require a secondary dressing. It all depends on whether it's a composite or not. Just a note that these honey dressings can look really gooey when you take them off, so make sure you're cleansing the wound well or having wound hygiene when you remove it. And at applications, some patients do complain of stinging that may be related to lowering of the pH. This week on wound dressing categories with Lizzie, we're going to be discussing transparent film. So this has no ability to absorb anything. It's just a polyurethane membrane with an adhesive, usually an acrylic adhesive, on one side of it that sticks to the epithelial layer of your skin. It can retain moisture, but it allows gases through. So if any exudate is coming from the wound, you're going to see it collect underneath. It's not going to pass through or absorb at all. If you have a patient with fragile or delicate skin, you would want to use caution with transparent films, potentially even using a skin protectant underneath it. The other thing that these are great for is as a barrier. So they're waterproof and they can help protect the wound from the external environment. They make an excellent secondary dressing. They can stay in place for up to 7 days. And just a tip with removal is if you lift just the corner and then pull the corner of the transparent film to allow it to stretch so that you can easily take it off, you're going to avoid a medical adhesive related skin injury. These dressings may not be a great option if your patient has very oily skin or sweats a lot as well. Welcome to Dressing Categories with Lizzie. Today we're going to be talking about hydrogels. Hydrogels offer moisture to the wound bed, so it's often used in a dry wound. If your wound has moderate to heavy exudate, it is not appropriate for a hydrogel. Hydrogels can come in a variety of different types, so it could be in a literal gel, like a tube, a gel, or it could be in a spray, it could be in a sheet, or it could be blended with another ingredient like an alginate. If it comes in a sheet, you can often get away with changing it every 3 days, but if it's a gel itself, we often change it every day because it will dry out otherwise. The gel itself requires a secondary dressing, whereas sheets may not. It may just require a securement device. So things you want to watch out for are maceration. Patients may say that this is like a cooling effect, and it's often nice for more superficial wounds that may not have the drainage. So think of like a road rash or a brush burn or something like that. Often good for skin tears as well, as long as there's not too much of a flap loss and the bleeding is controlled. So tune in. We're going to go through all the dressing categories